Hi, everybody. My name is Erin Stever. I am the Chief Programs Officer at SmileTrain, and I am really excited to welcome all of you to this very important teleclef panel, Why Strong Anesthesia Systems Are Key to Pandemic Preparedness, the SmileTrain Africa Experience. And now I'm going to pass it over to my wonderful colleague, Dr. Faye Evans, who is going to moderate the panel and introduce the other panelists.
Good morning, everybody.
Good morning.
Hi, so my name is Faye Evans. I'm a pediatric anesthesiologist in the US. I'm also on the medical advisory board for SmileTrain, and I am very pleased today to introduce you to our wonderful panelists. I'm going to be moderating this session, and I hope you find it really interesting and informative and a chance to engage them in kind of what's going on the continent as far as anesthesia, as far as what's going on with COVID, and hear from different areas of the continent what is happening. So we're going to start, and I'll start by my introductions. I'm going to start with Natalie Mejenji, and I think they're going to show up a slide, maybe.
Yes. Hi, everybody. Hi, Faye. Thank you.
Natalie, you want me to introduce you, or you want to introduce yourself?
I will introduce myself. Thank
Perfect.
you. Okay. Hi, Faye. Hi, everybody. Thank you. I'm Natalie Mejenji. I'm a pediatric anesthesiologist, and I'm working in General Hospital of Douala in Cameroon. Nice to meet all of you.
Well, let's continue with this theme. Dr. Anastasia, do you want to introduce yourself?
Yeah, I will. I'm Anastasia, an anesthesiologist with Komfanoshi Teaching Hospital in Kumasi, Ghana. I do some work with SmileTrain, cleft. I do some cleft cases. And then coming from the safety side of it, I also am part of the AHA training for SmileTrain. So I do both pediatric advanced life support and basic life support.
Excellent. And Dr. Fred Balumba, why don't you introduce yourself too?
Hi, thanks. My name is Fred Bulamba from Uganda. I'm an anesthesia doctor. I currently work in form employment at Positama University as an academic staff, but I'm also involved in SmileTrain as regards safety and quality of the services that SmileTrain offers. And I'm also on the African Medical Advisory Board for that, for the organization. Thank you. And thanks for hosting.
No, I want to thank SmileTrain also for hosting this. So this format's going to be a little different than some of these teleclef seminars. Instead of a lecture, we thought we'd bring together these three anesthesiologists to kind of tell their story. And we want to make it an opportunity for the audience also to ask any questions they might have. I know these have been discouraged in the past, but as we get started, if anybody out there has a question they want to ask the panelist or me, please feel free to put those in the open questions or the questions, and we will do our best to kind of answer them as they come up. So I think we'll just kind of get started. And we have a series of questions we prepared for the panelists, and we'll kind of go through them and have a chance to have that discussion. So first of all, I'm going to start with a question I'm going to ask each one of you. And one is, how is the COVID situation currently in your country? And tell everybody a little bit about the status of the vaccine rollout and the mass vaccination. Is this going well, not going well? Where do you think it's headed? And Anastasia, why don't we start with you, if you don't mind?
I'm okay with that. So I'm in Ghana. Like most other African countries, I think we have been spared the war we were afraid of. We are still in battle, but not to the proportions we had feared about a year and a half ago. We just passed the peak of our third wave. It's coming down. We are very happy about it. For a country of about 30 million citizens, we've had only about 125 cases. And then our mortality just a bit over 1,000 deaths. So relatively, we are on the better side of things. For vaccine use, we've had a couple of vaccination drives. The most common vaccine we have is the AstraZeneca. We've got some donations. The government has procured some. Initially, vaccination was mostly for just the healthcare workers. Currently, it's an open vaccination for anyone over 18. As at just about a week ago, we had vaccinated fully 2.5% of the population. It's woefully inadequate, but I'm sure by the end of this quarter, we are expecting about 10% of the population to be vaccinated. So I think it's not as bad as we feared. There's still a battle though. Thank you.
That is fascinating that your vaccination rate is low, and so actually in many ways is your deaths. It's pretty amazing and pretty interesting. As a person from the US, I have to ask this question. Do folks there wear masks? Is there any resistance to wearing a face mask?
So in the beginning, a lot of folks would wear the mask. Currently, people don't care. Mostly because, like I said, we never had the war we were afraid of, the hospitals overflowing, sick people in the streets. We didn't experience that. So the general populace, they are just a bit lackadaisical about it. Since I'm in the hospital environment, it's a bit different for me. It's a strictly mask area. Most government offices, you have to wear masks, yes. So people will wear masks if they have to, but otherwise, the average person really doesn't see the need unless they've had a close contact get sick. Then they become advocates.
That's interesting. Fred, why don't you tell us a little bit about Uganda? Because I think it's a little different there.
Question. For you, I think we're just working out of our June and July, where the thousands we had in July. So we're a bit happy about that. As regards vaccination, I think we're not any different from other African countries. So far we've vaccinated about 2 million people, basically getting at least one shot. And we hope that, with having more vaccine doses promised in the coming couple of months, maybe we'll have vaccinated about 11 million. It's the politics of vaccines, it's the politics of multitude from other countries, really.
Thank you.
Yeah. Unless you have any more specific things.
No problem. Thank you, Fred. Natalie, can you tell us a little bit about what's going on in Cameroon?
Yes, in Cameroon, like in other sub-Saharan countries, the prevalence and the mortality rate are lower in comparison with Western countries. Actually, we have had 80,414 confirmed cases with 1,368 deaths. Regarding pediatric data, they are not quite available. We just have hospital data, and the prevalence of COVID-19 among children is less than 2%, so it's not quite frequent. In terms of the vaccination status, we are starting vaccination in April. It was open vaccination for everybody. 3 types of vaccines are available. We have the Sinopharm, AstraZeneca, and Johnson & Johnson. Till now, we have administered more than, let's say, around 500,000 doses, and we have around 85,000 persons fully vaccinated. It's quite low, and we are encountering resistance among people, health workers, about the vaccine. So we're still having work to do to make a good coverage of vaccination among the population.
Do you think, Natalie, how has the COVID impacted surgical care for children and cleft care in your country? Have you seen a decrease, and are folks coming in even later than they already were, or has it not been much affected?
COVID has quite impact on surgical care. We have a real decrease of attendance in the whole hospital, even in the a lot of non-emergent surgery have been postponed. So, and we are running out of stock of sedative blockers. We have a lack of oxygen supply because they are completely oriented for COVID patients. We have reduced human resources because a lot of patients are getting infected with COVID, and increased use of consumables. We have also a problem with PPE, personal protective equipment, and other medication.
Anastasia, is this different where you are in Ghana, or is it similar?
It was similar some months ago, where we faced brief shortage of oxygen, but generally we've had individuals, philanthropists, and then the government pull through, and currently shortage of PPEs is not really a problem. The main problem is getting enough staff motivated to want to do COVID care. That's the main issue. I mean, initially people were afraid for themselves, for their families. The government threw in some incentives, but currently those incentives have gone off. And for any healthcare worker who has been involved in COVID care, they'll let you, it's very demanding, it's very tasking physically, emotionally, and psychologically. So for anyone to volunteer to do COVID care, I mean, I think that's the main issue now. Yeah.
What about the kids who come in for surgery who aren't having COVID, who don't have COVID, who just need surgery? Do you find that those cases are getting delayed, or children are coming in later than they already were? And we already knew that that was a bit of a problem. Is it the problem worse, or is it the same, or
it's much better now. So for us, the main height of the pandemic would have been from March to August 2020. Then we had to suspend non-emergent surgeries. So definitely, and people were afraid. People were afraid of the hospital environment. So we had quite a delay. We're not doing the electives; they were piling up, and then. But sometime in August, what we did, once electives were restarted or non-emergent surgeries were restarted. For instance, we have a comprehensive cleft clinic in Ghana. So what happened was, immediately during the time when we were not doing non-emergent surgeries, the children were still being seen. The nutritionists were seen, speech therapists, everyone was still reviewing. So once when we were having quite a backlog, you know, the mothers would come and they want the child fixed. They want to be able to take pictures of their children, show them to family. So what the cleft clinic did was, immediately cases were restarted. They organized 2 in-house outreaches, sort of like a surgery drive, where we cleared the backlog. And the fact that you are not doing surgeries doesn't mean that the children are not going to be born with the craniofacial abnormalities. It does not mean that they are not going to have their surgical emergencies. So I think even if we're not seeing them in our institutions, they were out there in the public, either getting some other care or not getting any care at all. Yeah, but currently, I think we are almost back to pre-pandemic levels, just a slight reduction in cases, but we are almost back to pre-pandemic levels.
Interesting. Fred, are you in Uganda at your hospital back to the pre-pandemic levels, or is it still kind of delayed? Because I think your wave was a little bit bigger than maybe either of the other two have faced.
Yeah, Faye, I think we're certainly back at pre-pandemic levels. The biggest change that I saw, and I mean without numbers, but the biggest change that I saw was the fact that people could just not come to hospital. especially during the lockdowns. We've had 2 lockdowns so far, and basically the numbers of all sorts of patients are reduced, including pediatric cases. But we did continue to undertake emergency surgeries. I mean, in most of our hospitals, 70-60% is emergencies anyway, even pre-pandemic. So the emergency surgeries continued.
I'm curious.
At my hospital, we specifically have a very good program for neonatal surgery. Yes, Faye.
No, keep going. I'm sorry. There's a little bit of delay. Sorry.
Apologies. I was saying that, we continued with emergencies, including neonatal surgeries. And what I observed is that the drives for cleft surgeries, not at my hospital, but elsewhere, continued, and children continue to access those services.
Thank you. To all of you guys, and I want you to think about this, you all are anesthesiologists. And, for many people in the country, they might not have known what that was. How do you think the COVID pandemic has really changed the recognition of who you are and also your role in your country and at your hospital? Have your responsibilities changed? And do you think this is here to stay, or do you think the way people view anesthesia and the specialty is going to go back to pre-pandemic once the COVID is taken care of? Fred, go ahead and answer that if you don't mind. Or
no, I don't mind. So for me, it's at 2 levels. At the national level, I think it's been a blessing in disguise. We've seen a lot of recognition of the services that anesthesiologists offer. We've had an opportunity to be involved in a number of government interventions, even when they didn't exactly know us before. But we've been supported by the government to do trainings. We've been involved in task force and other government programs, really. But for me, as a person, I think it's mainly been getting our role out there through, particularly my association, which is the Association of Anesthesiologists of Uganda. We've really engaged with a community, and I think that if recognition of anesthesia care providers was 0 previously, it might be at about 40-50% right now.
Thank you, Fred. Natalie, what about your role as an anesthesiologist and the public's view of what you do, and even other folks in the hospital in Cameroon? We may have lost Natalie for a minute.
Yeah, looks like
She'll
she's
try to
having
come
some
back in.
issues.
Well, Anastasia, why don't you answer that while we wait for Natalie to rejoin us?
So I think it's a similar experience to what Fred had. At the national level, suddenly everyone wants to know an anesthesiologist because, yes, travel is limited, so you can't just hop out of the country to seek medical care somewhere. So we have to make sure that if you do fall sick and there's a real threat of anyone getting critically ill with COVID, there's the facility available. So yeah, we were thrust into the limelight, and I think that has been a blessing, the only silver lining of the whole pandemic, because anesthesia is not when you are talking healthcare, most people do not focus on anesthesia care. In my country, I think anesthesiologists are about just 160 for a country of 30 million. Most of the anesthesia providers are from the nursing background, and they do not do the critical care part of it yet. So suddenly everybody realizes we do need more anesthesiologists. So I'm happy about it. There are a few policy changes to encourage more people to get into anesthesia, which makes me happy. At the local level, suddenly we were being called upon to sacrifice and be at the forefront. You are being called a hero, but the word hero comes with so much responsibilities. You are being asked to man COVID centers. You are providing care around the clock, putting your own health at risk in PPEs for a long period. So at the hospital level, I think there's been a big stretch of our human resources, which was already stretched to its capacity. At any given time, my department has had to have staff to do a 24-hour cover of our COVID center. And I know the main hospital in Accra, Kolebu, at some point basically had to co-opt almost all the anesthesiologists to man our biggest COVID center. And going to work in a theater for 8 to 10 hours and going home is different from going to work where you have to be in that close contact with very sick people, and there's a risk of you being infected. So I think nationally, it has been a sort of a blessing because we know everybody is talking about ventilators. Fine, order 100 ventilators. What happens when you have the 100 ventilators? You can't do anything with a ventilator unless you have someone who is trained to man it. So nationally, I think that's the only good part about the pandemic. But locally, we are really stretched and a lot of our folks are tired. People are psychologically drained. Burnout is very real. Yeah, so for anesthesiologists, that's the main thing. That's the main impact of COVID on our work.
Thank you for sharing that. I think that's really insightful. You know, you talk a little bit about burnout and you talk a little bit about just our safety as anesthesiologists being on the front line. And I think, you know, probably even more so in your country where there's so few anesthesiologists and there is really very little development of a true critical care specialty independent of anesthesia. You are the anesthesiologists, are the critical care providers. You know, Natalie, how in Cameroon do you feel like your safety is being provided for? And do you feel like the hospital and others are appreciating the burnout and that the specialty is tired and that the providers are tired? Are you back?
I do apologize. The connection is quite low. Hope it not shut down once again. But
that's okay.
Well, yeah, as the elder have said, we are on the front line and we are quite exhausted. We are overwhelmed. There is a huge need of anesthesiologists. I mean, all the politics have now understood that what is the real role of an anesthesiologist and how things should work if we have a crisis. That was the key adding value of the COVID-19. For our colleagues, the adding value of COVID is that COVID have enhanced team collaboration and also team communication. A lot of people, because of COVID, have tried as much as possible because it's quite demanding to give hands, to help each other from all around the hospital at the tertiary, secondary, primary level. And yeah, that's it.
No, I think that's good to hear. You know, one of the things, I'm going to give you an opportunity. Is there anything that you wish your surgical colleagues knew about your role during COVID that you're not sure they know? Or do you feel like, you know, that you're working together on the front line and they're aware of everything that's going on? Fred, anything to add there? Do your surgical colleagues really get it? It's your chance to kind of let them know.
Well, I think they kind of get it, but they kind of, yeah, they do. But what COVID meant was that the roads that we are known for were stretched, were thoroughly stretched. You know, spending long hours in COVID units. You also have other non-COVID patients to take care of. You have to do training for hospital staff. as well as other, external engagement. So they recognize that, but I don't think they know the magnitude that's affected us, and I totally believe what Anastasia says, taking it from my mouth. Burnout is real, and we've seen it here. There's something that happened which was a bit weird in Uganda during the peak of the pandemic. We saw a lot of non-ICU, non-HCU facilities mushrooming, and basically taking away from the little human resource that we already had, even for people who really had no idea of what an ICU is. They established a makeshift facility that apparently treats COVID as an ICU and HCU. So that made it worse in terms of our responsibility to provide.
Anastasia, do you have anything to add that you wish here's your chance to tell them or to let them know what they don't know or do know and thank them?
They do know. I mean, the surgeons do know we are tired, but not to be mean, a surgeon would always be a surgeon. He's interested in his cases being done. So whether you are tired, you are stretched, whether you don't have enough hands, once the list must be done, the cases must be done. So we just want them to know that they should understand that, like you said, we are tired. We are tired. For instance, if you have 5 people to run an OR and the COVID center is choked, we would have to take people out and we would necessarily have to cancel certain cases. It's difficult because they are the ones who have to go back to the patients and let them know surgery is not being done. So we understand where they are coming from. But I think we would all appreciate a break. If we could, all anesthesiologists could just go for like a 1-month vacation and then reset. But of course, so I think they do understand what we've been through. We appreciate that, but we still need to pace ourselves. We need to pace ourselves. We can't just throw ourselves fully into pre-pandemic mode. No.
I think that's a really good point around pacing ourselves, because I think everybody's in overdrive right now with everything that we do, and that we don't want burnout anywhere, and that really pacing ourselves and knowing that we're all in it for the long haul. Natalie, anything different you want to tell your surgeons, or you wish that they knew that they don't, or you don't feel that they do, around what you're doing during this pandemic? We may have lost her again. I'll keep reaching out to her. Oh, as we go. That looks like we lost her again through the connection. I'm going to switch gears a little bit and talk a little bit about Smile Train. And, everybody is very familiar with them, and I know all of you are, around their commitment to comprehensive cleft care. But what folks may not realize is that a lot of effort and funding has gone into the response to the pandemic, both internationally and at country levels, by Smile Train. And I thought it might be a nice opportunity for you to kind of tell what Smile Train has been doing locally during the pandemic, for you and for your patients, to try to help deal with what's going on. Fred, do you want to kind of share what's been going on in Uganda and how Smile Train has been involved, maybe outside of the cleft care?
Right. So I will not speak specifically at hospital level, but what I've seen happen across Africa is Smile Train's commitment to supporting equipment that were critical in the pandemic, especially partnering with Lifebox to distribute the Lifebox power oximeters, which will not be a bit of a game changer. They've also helped severally as regards provision of personal protection equipment, as well as really providing the platform where persons from different countries, from different continents, can really interact through their series of webinars on cleft care, on COVID, in other areas. I think that has been the most significant input away from the performance of the surgeries themselves. I submit.
No, I think, Fred, that's a great description, and it's a great example of how people shift in what they do during emergencies like this, and that Smile Train really has done a lot during this period, especially when all of the surgeries a lot of the elective surgeries were stopped because we needed to reallocate resources, and also we weren't sure if it was safe to be doing the surgeries both for the patients and for the healthcare provider. Anastasia, you work more in one of the cleft centers where Smile Train is quite active, and you have a Smile Train surgeon. How have you seen their role being different during the pandemic? Because I know Fred does not work in one of those centers, so it's a nice contrast.
So in Ghana, Komfanochi to be specific, we are lucky to have the first ever Smile Train Cleft Leadership Center. We actually have a cleft clinic. Our clinic operates on the comprehensive cleft care concept. So we have nutritionists, we have all the various components. We have pediatricians, ENT surgeons, speech therapists. Everyone gathers in the same place to see the kids. They come on Wednesdays. During the pandemic, like I said earlier, the clinic continued to run. The only exception was the anesthesiologist had to be withdrawn. So, well, makes sense. We're not preparing for surgery, and anesthesiologists were needed everywhere. So we had to take away the anesthesiologists who were taking part in the comprehensive cleft care to reassign them. Looking at bringing them back. But the good news is our anesthesia clinic was just about 150 meters away. So the patients had to just walk over to the clinic and join everyone else. The period, let's say the fallow period, spent a lot of that time in training. So for instance, like Fred said, we partnered with Smile Train and Livebox on the pulse oximetry courses, did the hypoxia action plan. We also had some training on the surgical safety checklist, looking at the COVID adaptation. So we spent time learning. I was lucky to be involved in pediatric advanced life support. This one wasn't virtual, this was done in person in Nigeria. So I think Smile Train spent the time preparing people, waiting for when things would open up. So we spent that time learning and then adapting our policies.
No, it's nice to hear that everybody thinks about the efforts that have gone on around PPE, which I will agree are super, super important. And they always think about the stuff, but what's really nice is you really focused on the education that happened during the pandemic and how Smile Train with its partners was able to really expand educational opportunities that helped us to be better adapted to dealing with both the pandemic and just taking care of our patients in general. So, and I think you also highlighted earlier that education or the lack of education is one of the problems. So I think that's a nice silver lining to what's happened. Natalie, are you back? I see her, but again, I'm not sure she's here. Oh.
Yes, Faye.
No,
sorry.
Don't apologize. You can't control the network. We were just kind of talking about a little bit about, everybody knows of Smile Train as and their commitment and their work as a comprehensive cleft care charity, but they've done a lot of work outside of this in response to the pandemic. And I'd be interested to know what kind of work they've been doing in Cameroon, you know, as far as during the pandemic and how you felt their efforts.
Okay. Smile Train has provided a lot of education opportunities like this teleclef series through training, continuous training. Smile Train has supported the institution by providing PPE and sanitizer, pulse oximeter, and even thermometers. And something which I found quite great is that they have updated the WHO checklist to help all providers to do surgeries during the pandemic. This COVID checklist helped a lot to maintain or to respect how you show you how you wear your PPE, how you have to manage. I feel it quite great. So that's what they have provided.
That's good to hear. You know, you talk about the WHO surgical safety checklist and the COVID checklist that's meant to be done with the WHO surgical safety checklist. If folks out there haven't heard about this, it's reach out to Smile Train or to Lifebox and you can get a copy of it. But it is really a nice checklist, really geared more towards the healthcare provider instead of around patient safety. It's an addendum to be used when you're caring for a COVID positive patient to make sure that the folks in the operating room providing the care stay safe. An interesting question came from the audience, and it has to do with what percentage of your patients who are coming for elective surgery are being screened for COVID, and then more specifically, really around the cleft patients and any of your patients, who's paying for this screening? Fred, you're not taking care of many cleft patients per se at your hospital, but let's start with you and ask you what percentage of your patients are getting screened for surgery before they come for surgery, for COVID, sorry.
Yeah, only those who have symptoms. So what happened in Uganda was that the government came out quite early in some of its guidance and standards and said there should be no screening in terms of testing for COVID unless someone has symptoms. And so in most of the public institutions, you will not see interest as regards COVID tests, whether RDT or PCR, unless when someone has a clear indication when there are symptoms. And this has mainly fallen on the anesthesia providers who screen, who interact with the patients before surgery, and if they can cut anything, then they go ahead and screen. In the private hospitals, however, there are those that have mandated screening for all surgeries really, who have mandated screening for COVID, and the patient then foots the bill, but that's in the private sector.
Fred, I have to ask you, because I think how do you feel about that? Are you okay with the fact that patients who are coming to the OR aren't screened, or do you just kind of approach it like everybody has COVID and you're in an N95 at all times? I mean, how do you deal with that being really, truly a frontline provider and being exposed?
Exactly how you said it. So we as a group, we appreciated that, your next patient, irrespective of whether they have symptoms or not, could be a COVID patient. And so what we did was to make sure that that all anesthesia providers in the country have access to, the bare minimum PPE standard of an N95 or KN95. And so we've had a drive with my association where we've actually distributed these to a number of course, not exhaustively, but to a number of anesthesia care providers. I'm also cognizant of the fact that our economy and how much money has been put into this does not enable us to do screening. But I know that there are cheaper and cheaper ways of doing this that are coming up. And so hopefully we'll see this. I think we should just prospect it and go on.
I have to ask you one more follow-up question to this, and then I'm going to ask the other panelists the same question. What, with the lack of screening, and I know the limited PPE, but you do have it, what percentage would you say, or how common is it for an anesthesiologist or somebody in the theater to get COVID from a patient? Do you think it's high, low, unsure?
We've had a couple of anesthesia providers get COVID. It's very difficult to know whether they got this from the theaters or from the ICUs they're working on or from the restaurants. but certainly a significant number of colleagues have actually ended up getting COVID, but we can't really say.
Okay. Man, it's kind of scary, you know, but you're right, you don't have a choice. Natasha?
Yes.
Anastasia, what do you think about this? Anything different in Ghana?
Okay, so for us, apart from for travel purposes, COVID testing is covered by the government. However, for patients, all patients coming to the hospital have to go through a checklist. We want to find out if they have a temperature, upper respiratory tract infections, if they've had a contact with a known COVID case. So there's a sort of screening tool before. Yeah. So every patient would have had that, so that to reduce the likelihood of us having patients with COVID. For the anesthesia providers, we are past the issue of reusing N95s. We have enough there. So basically, for every airway case you're going to manage, you should be in an N95. I think when we do have suspected cases, it doesn't take long to get PCR results now. We have a couple of labs that are running them. And like I said, the cost is not coming from the patient. So you are able to turn around time between 12 and 24 hours. So unless you have a dire emergency with symptoms and you suspect COVID, in which case you'd rather go in as though it was a COVID case. We don't have issues of cases where you are not sure what the patient's status is, because they would have first gone through the screening tool to point them out.
So the screening tool is used, and if they have any red flags on the screening tool, then you'll do the test.
Yes.
Is the way you do it. Okay.
Yes.
And then if they were positive, how long would you typically wait before you would offer surgery if it was elective?
If it was elective and they were asymptomatic, then we are not going to have to do the surgery. I mean, if it's elective, you would want to wait until they've recovered fully and reassess, make sure they don't have any any other physiological issues, especially with the respiratory tract, before you'd go in for elective. So definitely electives, no. Emergencies, then you'd have to liaise with the COVID center and then have a separate protocol, because it's an emergency and it can't wait. Yes. I mean, we've had a few pregnant women have COVID. Yeah, so that's where the WHO COVID adaptation for the surgical safety checklist comes in.
Got it.
So that goes along a different line, but for the general population and the anesthesia work, you don't get confronted with positive COVID cases out of the blue. No.
And in Ghana, in the public system, the government is paying for the test.
Yes.
Which is, and then Fred, back to you in Uganda. If a patient needed a test in Uganda, let's say they were symptomatic and you weren't sure whether it was a cold or COVID, who would pay for that test?
It's free. It takes a bit of time. Maybe PCR is now about 24 hours. Our RDT is about 20-30 minutes, but it's free if a patient wants it. Of course, if they're in the private setting, then they have to pay for it.
Excellent. So the private setting, that they do have to pay for it. Okay. What about, so I'm going to switch gears again, and I want to think about another silver lining, something positive. Are there any innovations that have come up during COVID, especially in regards to surgical care for children or surgical care for children, including cleft care, that you can think of? And I'm going to start with you, Anastasia. And any silver linings or things that have been developed, any innovations that have come up that you are just particularly proud of, or not? You know, it could be you're just surviving, and that's okay too.
Well, we are surviving. We are surviving. The main thing is, of course, we've got some pulse oximeters from Livebox, so increase as better safety, or if I may put it that way. But yeah, we are still working on a few things, and right now, no innovation per se. On my department end, not related to Smile Train, I mean, we have some video laryngoscopes so that, I mean, it's going to improve your chance of getting the airway secured on first attempt. Yeah, so we are trying to look at ways of moving beyond direct laryngoscopy, which has got much closer to the patient's airway. So not much innovation-wise.
Natalie, are you back with us? I want to engage you while we have you, but I know your connection has not been so great. We're just talking about whether there have been any innovations that have come up during COVID, especially in regards to surgical care for children, including those with clefts that you can think of that have happened in Cameroon or not.
Okay. What happens is that with COVID, and because we are not able to have all the narcotics, we are running out of narcotics. We have developed ambulatory anesthesia, and we have also increased regional, especially regional anesthesia. So that was what has changed. And regarding also, sorry, I've lost my idea.
That's okay.
I have to think in French and English. So regional anesthesia and ambulatory anesthesia. That has changed mainly. What has changed mainly.
That's interesting. I didn't get to ask you this question, and I am curious because Cameroon, we don't hear as much about here in the English-speaking countries. What's going on with testing there? Are you testing everybody who comes to the theater before surgery for elective cases? And when you do test, who pays for it?
Okay, in the early stage, we were not able to test them because we didn't have enough tests. We were not organized. But at the tertiary and the secondary level, now we are able to test everybody for elective surgery. And we have extended even to neighbors who are coming with the patient in the hospital. So now we are able to do that, but it was not possible in the early stages. But in the main town, like in Yaoundé, in Douala, I think with the support of all the partners, we will be able to test, to continue to extend it to the other areas.
What happens in the district hospitals or the smaller centers who still do surgery?
For elective surgery is not possible right now in the district hospital, especially for asymptomatic patient. But for symptomatic patient, they know that they should test them.
And is it free, or is the government paying for it, or?
No, it's free. It's free.
That's a nice theme that we're hearing across the board, at least in the public system, that it's free. That's fantastic. Fred, any innovations that you've seen come up during COVID, especially in regards to surgical care for children, including those with cleft, or just children in general?
Not anything that I can put my finger on, but one exciting thing that I've seen coming from Smile Train actually is how we're doing our safety reviews. We have a program where we evaluate our hospitals for surgical safety, surgical and anesthesia safety for all patients really, but with cleft patients at the back of our minds. And one of the exciting things that has come in is that we've piloted a kind of virtual assessment. And this is something that I'm looking forward to observe how it grows and changes. But as regards surgical patients, pediatric and cleft patients, really nothing really has changed.
No, I think that's interesting. Have you been able to use more video laryngoscopes, or not really, still not really readily available?
In fact, I want to work where anesthesia works, because that's how really like where we should all be going. We've not received any new particular video laryngoscopes. So it's only the hospitals that already had access to this that have continued to use them. But I have a general feeling that a lot of anesthesia providers are thinking into going in that direction of video laryngoscopy rather than getting as close as possible to the patient's mouth.
Right. Anastasia, I'm curious about your video laryngoscopes because we were having discussions about the use of them in a setting where the environment's not quite so kind. They can be robust, but they can also break pretty easily and they're expensive. Not as bad as a fiber optic scope, but what brand are you using? Or
I have to look at it again. I have to look at it. But we're actually pushing for more because we have just two. So you'd have to sort of know you need it in advance. Yes. So we are trying to push for more, especially the ones with the bigger screens, so that it will be more effective for teaching.
Are they holding up or are they breaking easily? I'm just curious from just on the ground.
So they are holding up because we are protecting them. You have to have request for access to them. And we have one in ENT maxillofacial theater because that's where you're expecting a lot of airway issues. And usually it's there, but it's not just in the open for you to pick up. Yes.
Got it. So the next question is going to be very relevant then. So you've got people on this webinar here who are from Smile Train and maybe others who are NGOs wanting to hear from you on the ground. What investments do you feel we as anesthesia providers and also the folks who are kind of thinking about the future, what investments should we be making now immediately and over the next 5 to 10 years? Where do you think we should be investing to really improve the quality of the care and the surgery that we provide for children and children with clefts? Where should we go? What's needed? Thinking past COVID. I've got you, Anastasia. Go ahead.
I think the first thing is to keep hammering on safety. Safe surgery, the best. Unsafe surgery is worse than no surgery. So keep hammering on safety. And with that, we are looking at the personnel, making sure personnel are retrained and trained, both as individuals and as teams. When you have teams trained, then you have better efficiency, turnover, everything improves. So yeah, the first thing is training. Closely, a big second is equipment. Pediatrics airway can be quite tricky, and a child's airway is not the kind of thing you want to go in and out and in and out. So like I said, I want a really big video laryngoscope immediately. Moving on with regard to training, we should look beyond individuals and look at establishing a system so that you have about 3-4 people working together. I know Smile Train is working to get us an ultramodern cleft center. I'm very happy about that. And with that, we are expecting that we'll have the equipment needs and the logistics to provide high quality cleft surgery. Being in Ghana doesn't mean that you have to go down to ITA for anesthesia. We want near infrared spectrometry. We want everything. And I think our children one day should get that. So yeah, and then I think that's the main thing. We should be looking at having world-class centers, if not everywhere, at least one per country, so that folks can go learn. In Africa, we have a weird, unique position. When we are learning, we get to learn to standard. But when you get on the ground to work, you have to modify what you've learned and apply to what's available. Sometimes in doing that, we tend to sacrifice a bit of safety, and it doesn't always end well. So currently, we have a new crop of anesthesiologists, and we are pushing for the best. We want the best for our babies too.
Anastasia, that was beautifully said. Thank you for sharing that, because I think it's really important for us to remember that we need to still focus on safety. And even when we don't have what we need, we still need to make it as safe as we can. Natalie, What do you think? What investments should be made? Anything different than what Anastasia said, or anything to add?
No, not really. She has really said it properly. Safety, training, update, team, build a team, and support, continuous support. That's it.
Thank you. Fred, anything to add there?
I think I'll just build on what Anastasia said. Safety, but the question here is how do you do that? And I think if we could put more effort on building a culture of safety within the hospitals or within our work environments themselves, to get more than just the anesthesiologists, more than just the surgeons, think about safety, to build a culture that is accountable and responsive to safety issues. I think that would go a long way. I don't know how you start building that, but that's where we need to be heading. And of course, equipment, I think capnography is coming in very, very strongly as one of the equipment that has been shown to improve safety. Video laryngoscopes, maybe in the next 5-10 years would be a big thing. But of course, for us here in Africa, mostly, it again goes back to quality training as well of anesthesia providers, of surgery providers, and nurses. I think that's going to be key. Thank you.
No, I think it's great. It's funny. I was about to ask you the next question, which is what's going to bridge the gap between plan and action. And I think in some ways you guys have all said it. It's around team building and working together to kind of focus on safety. Anything else, Fred, you'd add to that about what you think can bridge that gap between what you're saying we need to do and how to make it happen? What do we need?
Well, we need to engage stakeholders. We need to engage not just the development partners, but the governments. Our governments need to pay attention or pay more attention to surgery, to anesthesia, critical care. And I think that would, if we have their commitment, that will be a game changer. We need to see a lot more funding dedicated to this. We need to see a lot of more funding dedicated to training of specialists and providers generally. So I think we just need to engage as much as possible. It doesn't happen quickly, but in the end, I'm hopeful that you get there.
Natalie, do you think it would be helpful for NGOs such as Smile Train and others to help you engage with the government? Or is this something that you feel like the folks on the ground need to be figuring out how to do better to really for them to understand what's going on and how to put more funding into these areas?
It's both. It's both. The work is at two levels, and we need to bridge the gap. On the government, as Fred has said, should be completely engaged. We need more budget. We need them to be present. We need them to soften the rules, the laws. They are not maybe able to do everything. They may need also support. So that's what I can say.
Excellent. Before I ask Anastasia the same question, somebody has raised their hand. I don't know if I have the ability to bring them in, but if you have a question, please feel free to write it down and we will definitely pose it to our panelists. We've gotten a few questions, but we have time for more for sure. Anastasia, anything to add about building those gaps or bridging those gaps? How do we best engage the government? Is it by the folks on the ground? Is it by the NGOs? Is it another way? Any recommendations or suggestions?
Yeah, I think all stakeholders have a role to play. So, for instance, in my country, Smile Train works with the Ghana Cleft Foundation. So that's a voice that can push for, that can advocate for what we need. But generally, at the individual level, when you go to work, you identify gaps. It behoves on you to forward it up to the next level. If I need warmers, if I need warming blankets for the children, I can't just, it's not something that should go to the government. It should be able to go to the hospital administrators before. If that is delaying and an NGO is in a position to help, I could appeal to them in the meantime. But I think we should have a plan for procuring things. We should be looking at in 5 to 10 years, a situation where the partners can collaborate. For instance, I know we have some African surgeons who come to my place to build up on their cleft skills. That is nice. We should get to the stage where we can have this inter-partnership collaboration with small children just being a conduit to facilitate it. Yeah. I know for instance, Kenya has some excellent programs. We should be able to link up even at the level of the partners without necessarily waiting for Smile Train to spearhead it. I know Smile Train is always happy to facilitate, but I think we should look at more collaboration amongst ourselves.
And it's funny now, I think if anything, the pandemic has taught that we can do that using WhatsApp chat groups or using something like Zoom or other video conferencing. I think we always used to think it was too technologically advanced or expensive. And I think what we've all learned is it's really doable. And hopefully using these types of mediums will be a great way to collaborate more in the future. So I really only have one more question to ask each of you. And I know it's just been an hour, but I also want to be respectful of everybody's time. And I think you guys have done a great job kind of really providing to the audience kind of what is going on the ground as far as anesthesia, as far as what you're facing, and as far as ways to make things better. That is, unless the audience has any questions. But in the meantime, and I asked you to prepare this beforehand, so I'm not putting you hopefully too much on the spot. I'm going to ask each of you your call to action, and think about a stakeholder. It could be any stakeholder you want. What is your call to action? And make it brief. And this is your chance. Hopefully, someone out there is listening and maybe can really listen to that and engage based on what you say. And Fred, I'm going to start with you. So here's your chance to tell folks, what do you think needs to happen? What's your call to action in about 30 seconds to a minute?
I think I'll go for the big one. That's our national government. I think I would like to tell them that it pays to invest in surgery, to invest in anesthesia, and to invest in training of these providers.
Thank you. Thank you very much for saying that. And hopefully somebody from the Ugandan Ministry of Health is listening to this, or we can find a way to make sure that they get a chance to watch the recording. Natasha, how about you? What's your call to action?
Since Fred has focused on the government, I want to focus on us as anesthesiologists. I think we shouldn't just stay in our theaters and corners hoping to make a change. We have to open up our specialty and let people know what we do and the challenges we are facing. I think that's the only way we can move forward. Yeah.
Thank you very much. And Natalie, are you there?
I'm here.
Excellent.
I'm here.
I want to hear your call to action. And why don't you say your call to action in English and then repeat it in French?
Oh, I can do it in
Be
French.
able to be a little more passionate in your native language.
I will do it in French. So.
Go for it.
All right. So, j'aimerais à tous ceux qui nous suivent déjà féliciter tous les efforts qui ont été mis en place pour combattre cette pandémie, et je souhaiterais un engagement véritable à tous les niveaux, que ce soit au niveau gouvernemental ou bien au niveau périphérique, pour améliorer la prise en charge de nos patients. En sus, une collaboration des diverses composantes serait un plus. Voilà. Thank you.
Thank you, thank you, thank you to all of our panelists. I really appreciate you taking the time this morning to come and really share your story with the rest of the Smile Train community. Aaron, would you like an opportunity to come on and say anything? or any questions before we wrap up the webinar? I put you on the spot there. Uh-oh, sorry.
Can you see me?
Yes.
Yeah, this was such a fantastic discussion. Thank you all so much for your insights into what's happening across the continent, for helping us all recognize how essential anesthesia is to safe surgery and really to the whole healthcare ecosystem, particularly right now during COVID. And lastly, I really appreciate all of the calls to action. My French is very rusty, but I will watch the recording and figure out what you said now. But honestly, this is a critically important topic to Smile Train and you know, to the world. So I'm thrilled that we had the opportunity to be together today, and we look forward to continuing to move forward anesthesia in Africa and around the world through Smile Train support. So thank you everyone so much.